The broadcast is now starting. All attendees are in listen-only mode.
Well, hello, everyone. I was going to say good morning because I'm in California, but I should probably say good morning, good afternoon, and good night. That sounds like a line from a movie. So I'm Victoria Dickerson, and it's been my delightful pleasure to be the organizer and the moderator of these Family Process Institute webinars. And today we have with us John Malpas. I will introduce him shortly, but before I do that, I want to do a little housekeeping. Besides being the organizer of the webinars, I also am the associate editor of Technology and New Media for Family Process, and that's one of the reasons that we have this webinar initiative going. We've successfully done 5 webinars, and we have more coming, so we are happy to have you with us. I also want to mention that Jason Black, you don't see him, but he is on this webinar as our manager of the webinars and also our marketing person. During this webinar, you will be on mute, but we want this to be an interactive webinar. So we encourage you to ask questions. There is a question box in your control panel on the right side of your screen. You can type questions in there at any time. Jean is quite willing to take questions during the webinar after each section, and he's suggesting that you ask clarifying questions if something is not clear or if you want him to expand a little on something. But there will be a Q&A at the very end, 20 to 25 to 30 minutes of Q&A at the end, where we can discuss things more in detail. I think the format will be clear to you in John's slides. You will see what he's doing there, and you'll know when we'll be able to ask questions. But please type them into the question box, and I will get them and pass them on to John. So there also will be a little bit of time at the end of this webinar to show you how you can access John Malpas' articles that are in Family Process, and those become free to you to download because of this webinar. So I will show you how to do that at the very end. So now let me introduce Sean. I'm going to read his introduction so it can be a little bit more formal. John is the director of the Gender and Family Project and the International Training Program at the Ackerman Institute for the Family. He has presented on issues of gender, couple, and family therapy in Argentina, Brazil, Belgium, Canada, Chile, Israel, Turkey, Thailand, and the United States. He's published several articles and book chapters on his work with lesbian, gay, bisexual, and transgender individuals, couples, and families, including the Family Process article, Between Pink and Blue, a multidimensional approach to gender nonconforming children and their families. And that's one of the articles that we'll make available to you. Just got a little noise here. John is on the editorial board of the Journal of LGBT Family Studies and a board member of the American Family Therapy Academy. John's leadership was recognized by the first Early Career Award of the American Family Therapy Academy, and I got to be present for that. That was a wonderful, wonderful experience. The Gender and Family Project was awarded the first Family Process Institute Early Career Training Grant, which I also was part of, which I'm delighted to tell you. John also maintains a private practice in New York City. So I welcome you all to this webinar on 50 Shades of Gender, a multidimensional approach to families with gender-expansive children with transgender adolescents. That's a mouthful, John. It's all yours.
Thank you, Vicki. Thank you very much. First of all, thank you for facilitating this webinar. Thank you for inviting me. I'm delighted to be with you, and I'm delighted to be with everybody here present today. I was just thinking it's my first webinar, and it's kind of interesting to welcome all of you in my office here. It feels like it's doing TV, but from my office here in New York City. I'm in Manhattan. It's about 12:30 p.m. in the afternoon, so welcome to New York City. It's Wednesday afternoon, and I hope that you will enjoy this presentation. We will talk about how to work in a systemic way with gender-expansive, gender non-conforming children, transgender adolescents, and their families. I'm going to go over a number of sections in this presentation. The presentation will be a little bit under an hour, and then we'll have a good 20-25 minutes of Q&A, as Vicky mentioned. So I want to tell you a little bit about where the work comes from, and particularly the Ackerman Institute's Gender and Family Project. And then we'll look at the theoretical framework that we use at the project, which is really looking at how we define gender and sexual identity in a contemporary way. And then we'll look at, again, sort of systemic and relational work with parents and what it's like for parents to parent across identity differences. And then we'll end with a little bit of background research on the developmental pathway of the sort of longitudinal information that we have about trans and gender non-conforming children and how they grow as adolescents and as adults. Then I will go into kind of taking you through the clinical framework that's actually described in the family process article Between Pink and Blue, which is a multidimensional family approach that includes different modalities, from working with parents to working with the entire family, working with children alone, working in a family setting, working in a group setting, doing both evaluations as well as really an affirmative, systemic, social justice-oriented work. So we'll do that. I hope to cover as well some of the kind of concrete clinical tools that I think are very helpful to engage children and families. And then we'll end with two clinical vignettes that I hope will illustrate a model that is both gender affirmative and also anchored in thoughtful, research-based tools, and also illustrate the complexity of working with gender-expansive kids and their families. So let's get started. So let me tell you a little bit about the Gender and Family Project. Was actually created in 2008. And the way it came about is it was actually started in my private practice with a few families, two families who were seeing me because their trans kid, who was at the time 10 and 12, had come out to them as transgender and wanted to transition really young. And I was working with them as a family therapist, and at some point thought they really needed to speak to one another, that community, that they felt alone in the world, and they needed to meet one another. And I offered to create a group, and that group started with two families. And before we knew it, we really outgrew my office and moved to Ackerman. Ackerman welcomed us, supported the project, supported the academic component, the community component, the social justice component of it. And we wanted to create a clinical team that really empowers youth, families, communities with gender affirmative services, but also training and research. So what we offer right now is a number of multidisciplinary services. We have family therapy, parental coaching, we have evaluation, psychological evaluations for children and adolescents, and we also have a number of support groups for parents, support groups for kids. We have a play group, we have a support group for teens, and we're opening a also multi-family group for Spanish-speaking families. So we really believe in this multi-modality approach that allows families to learn from their own process, to learn with a supportive professional, and also to learn from the community. We've seen actually over 60 families over the past 3 years, and we have trained just actually over the past year more than 500 professionals in the medical, mental health, and educational fields. And really, that's our mantra, is acceptance is protection. And we work a lot with Caitlin and Ryan's Family Acceptance Project research. We really look at where the family comes in, where they are in terms of their ability to be accepting of the identity of their child, and try to differentiate the work between rejecting families, ambivalent families, accepting families, but really with the idea that we need to be where the family is at, and we need to support them loving their child the way they want to love them while integrating the gender complexity that the child presents. And once that happens, they are the best equipped to protect their child and be there for what they need. So let's take a step together forward with the sort of the framework of this work, and we'll go over 3 sections: what's gender and what's sexual identity, parenting across difference, and then research. All right, so what is gender? And to some of you, this might be familiar territory. To some of you, this might be new. I'll be very curious to hear about that. But this is good sort of language to all have as a common basis to get. So gender is made of 3 components: sex, gender identity, and gender roles, and is different from sexual orientation or sexuality. And that's often a very important distinction when we do trainings in school. I just did yesterday, Monday actually, a training in elementary school in New Jersey, and we trained the entire staff and the entire faculty. We're going to be doing a training with parents, and it's one of the questions that we got is it a little early, 2nd, 3rd, 4th, 5th grade, to talk about sexuality? And we made it very clear that a gender inclusivity training is not about sexuality. It's about gender, it's about our sense of self, and of course it overlaps with sexual orientation and sexuality, but it's not what gender is. So the first component of gender is sex, and is I'll define it as the biological, anatomical, organic sexual markers of the body's sexual differentiation, which of course is assigned at birth based on genitals. So that's usually a question that I ask the audience and say, how do we know if we're male or female? And people say, well, I don't know, hormones, chromosomes. And I say, well, really, do we actually know hormone level and chromosomes as we, during pregnancy or at birth? No, it is based on genitals, and it's based on a binary model of sex. So if there is a penis, the child is assigned male, and if there isn't, the child is assigned female. But we actually know that that binary is not accurate. There are more than 2 sexes, and about 2% of infants are born with intersex conditions, or more technically called disorder of sexual differentiation. More than a large number of conditions that are invisible to the eye of people who actually are somewhere on the male-female biological spectrum. So intersex conditions are different from being transgender. There is, again, an overlap that we won't have the time to go into. But again, this is just to let us know that our binary conception of biological sex is erroneous, and that the reality is closer to this continuum. Gender identity is different from the biology. Gender identity is a unique self-conception. It's how we feel inside about our sense of being a boy or a girl, a man or a woman. It can be congruent with the sex that we were assigned at birth, with our body, or how we're socialized to be a boy or a girl. If it is congruent, then we are cisgender. Cis means aligned with. So it is when biology and sense of self are aligned. But sometimes it's not congruent. Sometimes our gender is not based on an organic component, or is not aligned with the way we're socialized to be, and that is what we call transgender, which is a large umbrella that includes a number of other identities and self-labeled identities. So gender can be binary. Some people identify as a boy or girl, a man or woman, and some people don't, and identify as both, as in the middle, as transgender, as genderqueer. We have a number of children in our play group. We have about between 15 and 25 kids who come once a month. And a number of them under the age of 10 actually identify as somewhere in the middle, and use and prefer to use the pronoun they. And it's really fascinating to hear how a kid, at the age of 7, without sort of being prompted or induced or taught that, will come to that conclusion and say, I'm both a boy and a girl. I really am not just one, and so it's he and she, and that's 1 and 1, and 1 and 1 is 2, and 2 is plural, and plural is they, so I'm a they. So queer theorists have been using they and as a way of as a political claim, as an academic position, And then some kids are coming to it really from the kind of really sense of themselves. So this is the binary model of gender identity that we're sort of, that's in the water, that we're, you know, kind of breathing and drinking all the time. If you're born male, you're supposed to identify as a born and a man. If you're born female and assigned female at birth, you're supposed to identify as a girl or woman. And there's an assumption, a cisgender assumption, that, but some kids don't identify this way and feel like they exist on a fluid spectrum. And some kids like Jazz, who is a young girl who is now 14, who a few years ago had an interview with Barbara Walters on 2020, and was one of the first kids in the U.S. to really put a name on sort of the phenomenon of transgender kids and talk about her own experience. So let's see what she said.
If someone asked me why I used to be a boy and now I'm a girl, I would say that I have a girl brain and boy body, and I think like a girl, but I just have a boy body, and it's different than you.
Is it okay to be different?
Yes.
Do you like it? Because why?
It's okay to be different because it just matters who you are. It doesn't matter if you're different than anybody else. It just matters if you're having a good time and you like who you are.
Okay, so I don't know if you got the actual image or if you just got the sound. It looks from my screen that you only got the sound, so I apologize about that. But as you can hear, Jazz is, and my screen is now freezing, so let me just come out here for a minute. Okay, I will go back. Okay, so what Jazz was saying is that she very much feels like she was born in a boy's body but has a girl brain and thinks and sees herself as a girl. So she was born on the female and assigned male at birth and is identifying in a quite binary way right now as a girl. Gender expression, the third component of gender, is different from gender identity and sex, and is how we express masculinity and femininity. And obviously this is socially induced and taught and variable through time and cultures, but we all know the sort of the stereotypes that include boys play with trucks and girls with dolls, and boys are supposed to wear pants and not skirts, and girls can wear skirts and pants. But it does vary through cultures, and I don't know if there are any history buffs here today with us. I don't know if you know who this is, but I'd like to take that picture because this is actually Louis XVI, French king, a couple hundred years ago, and this painting was actually sort of supposed to depict the sort of the epitome of masculinity, and as you can tell, he's wearing somewhat of heels, tights, feathers, gloves. He has a wig, he's got makeup. So obviously what we define as masculine and feminine really varies over time. And then this is a picture that my colleagues at Gender Spectrum often show when they talk about gender. This is, again, I don't know if any one of you can guess, but this is FDR, one of our former presidents, who at the age of, under the age of 3. And again, it looks like like what we would say now, a little girl. White dress, little socks, black shiny shoes, feathers in the hat, long hair. And at the time, this was the proper way to dress a boy at his age and his social class context. So again, the gender model of gender expression that we live with and are socialized to follow is that if we are male, we're supposed to identify as a boy and be masculine, again, be cisgender, is same for women. But some kids don't, again, agree with this. I hope you get the image with this one. This is Haley Riley talking about gender roles and how that affects her.
We're here for all the girls to buy princesses and all the boys to buy superheroes.
Why?
Because girls want superheroes and the boys want superheroes and the girls want pink stuff and the girls and the boys don't want pink stuff. Yeah.
Boys want both, but why do you think they do that?
Because the companies who make these try to trick the girls into buying the pink stuff instead of stuff that boys want to buy, right?
Right, but you can buy either, right? And boys can buy either. If boys want to buy pink, they can buy pink, right?
Yeah, so then why don't all the girls have buy princesses? Some girls like superheroes, some girls like princesses. Some boy like superheroes, some boy like princesses.
Absolutely.
So then why does all the girls have to buy pink stuff and all the boys have to buy different color stuff?
It's a good question, Riley.
I think she's adorable, and she is asking very good questions, and as you can tell, she's very angry when she realizes sort of the box, the pink box, the blue box in which we are put, and she has some good theory about maybe some kind of economic aspect of this. But as you can also hear, and I want to bring your attention to the role of her father in the video, which sort of lets her thoughts come up and also very gently help her unpack the gender binary when she has a hard time at the beginning saying, well, boys don't want pink stuff, right? And the father very gently says, well, boys might want both. And I think that's really a good example of socialization outside of the binary, again, sort of letting her know that things don't have to be stereotypical. Also, a question that we often get is this, is gender variance sort of a Northwestern, an American, a European phenomenon? And anthropology has shown that transgender people and communities have existed in different kind of countries and cultures and communities all around the planet, and often oppressed and sometimes also really elevated and valued for their particular position in society, such as the Two-Spirit community in the Native American tradition, where Two-Spirit people have both the mind of the moon and the mind of the sun, the mind of women and of men, and can understand both, and therefore have special powers and ability to mediate and counsel, like couples counselors. Again, that's the model that we work with, that separating sex, gender, and gender role or expression and looking at it as continuum. Now, that is different from sexual orientation, and which is who we're attracted to, who we like, who we fall in love with. We know the categories, are growing over time. It's straight, gay, lesbian, bisexual, asexual, pansexual, but it is different from gender, and I think that particularly when we work with younger children and gender-expansive, exploring, or transgender kids, it's very important to differentiate these two categories, sexual orientation and gender. So again, our sort of heteronormative, cis-normative model here, assumption of cisgender identity, assumption of heterosexuality, and then a more probably representative model of the communities that we work with, separating these four different dimensions and looking at them as fluid continuum. So just to show you, a shout out to my colleague Aaron Jensen, who did this slide, psychiatrist at the Child Study Center here at NYU in New York, just to show you that gender identity actually emerges really young. Some kids have a sense of themselves really as young as 2 and 3 and is fairly stable around, they gain gender constancy around the age of 5 and 7. It doesn't mean that a child will not change their mind or discover more about their gender identity as they grow older, but it means that when kids come out at the age of 3 or 4 or 5 or 7 and saying, I'm not comfortable as a boy or as a girl, I'm not a boy, I'm not a girl, I know in myself that I am something else, or that I am identifying with the gender, the other gender, there is a chance they might be onto something that at least we must listen. That's a sort of I didn't invent this either. The gender-bred person is a very nice way to talk to kids about gender and saying, gender is made of different things. There's your brain, how you see yourself, how you think of yourself. And gender identity, there's the body you're born with, that's your sex, that's your biology, and then there's your expression, all the things you are and how you express them. And then your orientation is who you have a crush on, who you like, who is special to you. So there are ways to speak to kids, and they really get it very young. I will move to the next piece of the theoretical framework, parenting across difference. So let me look at, and I'm going to...
John, can I interject something here? So I've got a quick question. Can I ask it now?
Mm-hmm.
This is a question from the audience.
Yep.
Okay. The question is, my 3-year-old grandson loves to wear headbands, tutus, twirling dresses. So far, only time he's asked to wear them was to daycare on a fiesta day when everyone was dressing up. Any opinions about what to do or say if he wants to dress for school in tutus and dresses?
So we'll definitely come back to this, but our sort of policy is let the child lead the way in terms of, to the extent that it's possible and that it's safe, in terms of their own gender expression and gender exploration. Let's not jump to the meaning of it, because a 3-year-old is expressing, sort of full range of gender expression and playfulness and exploration doesn't have to mean something definite about their gender identity, but I think that there's something really important about not making this young child feel embarrassed or ashamed about that fun, that playfulness that he's having with these clothes and these, and kind of follow and see what that means to him and see if he wants to do it in school again. I think that what we're getting to the parental functions, which is parents sort of are at the intersection of both nurturing and socializing, making sure kids are safe and fit in, and at the same time supporting the kid for who they are. So I think it depends on whether the environment is safe, whether the environment can be understanding, whether the environment can be educated about gender variance and gender expansion or not. So I think it's really on a case-by-case and contextual basis. So we're actually, great segue. The question of what are parental functions and what happens when parents are raising kids who have different identities than theirs. And a question that I asked myself for a long time as we were working with these families was that we start from the premise that parents love their kids and want the best for their kids and don't want to reject them. But yet we see that transgender, coming out of a kid as transgender or as gender expansive can really create a rupture in the parent-child relationship and can end up in rejection and socialization and isolation of the child. So we try to sort of understand that. And one of the ways that we're looking at that is we're looking at the different functions of parenting, right? Parenting, we're going to sort of look at 4 functions. One is nurturing the child, attuning to them, bonding, loving them, accepting them, discovering and supporting who they are. And then on the other end, transmission, passing on, defining characteristics about the family, and socializing, preparing the child to fit into social norm. So when a child is gender typical and parents share common gender norms, the binary of male and female, of masculine and femininity, in a way that there's 2 sets of functions, nurturing and acceptance on one hand and transmission and socializing, are not in conflict. There actually is an opportunity for bonding. A father will bond with his son, teaching him how he sees things that boys do and what boys do in school and things like that, and it's an opportunity for bonding. So nurturing and socializing are aligned. And everybody in the family shares this model of more or less. But in families where gender nonconforming, a family of gender nonconforming kids, 2 gender systems are sometimes in conflict. The binary imported by the parents and the social system and the fluid spectrum that the child articulates. So there is the old model and then there is this, and that's what's starting to create a conflict of norm and a conflict between the child and the environment, and a conflict of function for the parent. Do I nurture and accept my child for who they are, or do I prepare them, do I transmit my values, my identity, and also my social realities? Do I make sure that they fit in, right? And often what we see is that unfortunately rejection becomes a form of protection. Despite the love, despite the desire to really love this child for who they are, it is, if I have to scorn a little bit of that soul, a little bit of that identity just to make sure that they're going to be saved, that they're going to be alive, that they're going to fit in, that they're going to launch, I will do that. And that's often, unfortunately, the sort of where parents come from. It reminds me of Andrew Solomon's, I don't know if you guys know, his book, Far From the Tree, which is a wonderful book that I highly recommend, where parents have a conflict between vertical identities, the identities that are transmitted either by biology or by their culture or their family of origin that they want to transmit to their kid, and horizontal identity of the child. When the child comes out as transgender, in a way, they come up with an identity, a defining characteristic that has not been transmitted by the family. So we have a conflict of identities, a cultural conflict in the family. Now let's look at the reaction of parents of transgender youth and some of the common feelings that we can identify.
More than 4 years ago, Haley's parents, Barb and Steve, began to recognize that there was something different about their youngest boy.
From the time Haley could express herself, it really was feminine. She always gravitated toward dolls and flowers.
Right? But it wasn't just that Haley seemed to prefer girls' things, the pink side of the world to the blue. Something else was going on.
We noticed that she was depicting herself as a girl in all of her pictures. Any self-portrait was all girl, every time.
So what's this? I noticed that you have high-heel shoes on in your fairy picture. Fairies don't wear high-heel shoes, do they? They do? In kindergarten, Haley began to assert herself in a whole new way.
One day we heard from the teacher that Haley was in school having arguments with the boys, saying, "I'm not a boy, I'm a girl."
Then, Steve and Barb's youngest son, Harry, changed his name to Haley all on his own. Barb and Steve met with therapist after therapist. They heard the same word over and over again, transgender. But their child was only 5.
I remember the minute we were in the car, I just burst into tears.
And that moment was so, I don't know, profound. I mean, I felt like I got a dagger in my stomach. I was like, I was so angry. I was incredibly angry.
How could someone feel they were born in the wrong body at such a young age? Haley's story made me wonder how early we're aware of ourselves as male or female. For Steve, a Lutheran and Sunday school teacher, his child challenged the most basic beliefs he held.
I really had a far different feeling about gender and sexuality. I was embarrassed and felt, ashamed a little bit. There you go. Deposit. I still was believing that this was some sort of phase and this was not going to be permanent.
Do you think the possibility exists that this still may just be a phase?
I don't think that's going to happen now. If it does, it'll be okay with me. But I believe with conviction that my child here is exactly who she is. God made her just like this.
No one knows why people are transgender. There are only theories. Some think that it starts in the womb with hormone imbalances that change the brain to identify with the opposite gender. What is clear is that many transgender people are, like Haley, strongly aware of who they are inside at an early age. And this secret knowledge can lead them to a difficult future. Many transgender children grow up hating their bodies and fall victim to high rates of depression, drug abuse, and suicide. For Barb and Steve, the choice was clear: to support their child in order to save her from a future of heartache and pain. But they face a world that may not be as accepting of their choices. There are some people who might say you're encouraging this kind of behavior, that you are encouraging this little boy to be something that he's not. Mm-hmm. How do you respond to that?
I certainly didn't wish this upon my child. This is going to be a hard road.
I can't even get my children to use a napkin at dinner time. You know, you think I'm going to be able to get my child to change genders? I can't get her to brush her teeth at night, for heaven's sake. What we've done is finally come to terms ourselves with, you know, how to raise a healthy child instead of raising a child who feels some sense of shame or secrecy about who she is, you know.
For now, Haley's friends are accepting. But Barb and Steve know it's going to get harder for her.
Right now, right here, first grade's pretty safe, but the future can be really scary. They go into adolescence and puberty and then things get complicated.
The last few months have seen her becoming sort of more cognizant and more aware of, but other girls don't have a penis. Other girls don't have the body that I have.
Sometimes I sit there and I get really concerned, you know, who's gonna love my child, you know? Who's gonna fall in love with her?
For now, it's all about loving Haley as the little girl she feels she is. But the physical reality of being a biological male is going to catch up with her. What happens when a transgender child becomes an adult? I'm about to learn that that can bring a whole other set of challenges.
Okay, so I wanted to show you this because I think it does bring up a number of reactions that parents have, and, you know, from both the shock, the sadness, the shame, the embarrassment that they can have initially about having to deal with their child's identity, to also the sense of loss. I think that independently from rejection, from conflict of values, loving and accepting parents can also feel a sense of loss, a sense that they have to readjust their script. They have to think differently about how they were seeing that kid and the stories they were telling themselves about them growing up and meeting someone and going through sort of the cycle of life, and have to create a different story and let go of a certain story. So normalizing the loss and the mourning without taking that as a source of resistance or shame, I think, is really important. We heard the father talk about, you know, it wasn't his values. He was raised sort of religious in a certain way, but what's really beautiful is that at the end he is able to integrate his values. Say, God made my child this way. So that's also the work, is how can we respect the values of the parents, work with them, and yet integrate the reality of what the child is coming up with. And then, you know, what the mom says, we just want to try to find how to raise a healthy child. And often parents of trans kids are really scrutinized and blamed for, what did you do wrong? And she says, you know, I love that quote, I can't get her to brush her teeth, I think I can change her gender. And then, of course, the fears about the future, who's going to love my child. So grief, helplessness, and fear is really important. What can I do to protect my child? Their own coming out, they have to sort of come out to a community and to family about that. And then sometimes can create some serious triangulations and complications, as we're going to see in the case vignette. You know, what is really interesting is that family acceptance is really important. Family rejection has a number of detrimental consequences on youth, as sort of common sense would indicate. But research actually, again here by Caitlin Ryan, shows that, for instance, family rejection increases by 9 times the risk of suicide for young LGBT youth. And however, family acceptance increases by 3 times the likelihood of the young person to be happy, as well as, that's another slide I have, but as well as wanting to have children themselves. So when you welcome parents who feel helpless, who feel stripped of their own identity that they can transmit to their kid, that they feel they're sending their kid out on the street to be killed or hurt, and that they're not the best equipped, it often makes them feel so anxious that they have reactions that are not most helpful for the kid. But when you actually tell them that they actually have a tremendous power, and that their love, but more than their love, their acceptance, their embracing of what is happening is going to make this child stronger, happier, and also potentially wanting to have grandkids. That's actually really helpful for parents, and it helps them kind of coming along. So last bit before we move into the clinical work, here integrating research and an affirmative approach, basically when you're dealing with the treatment protocol, when you're dealing with a pre-pubertal child, that you do assess and explore the gender identity. If it's a gender non-conforming child, a child who doesn't want to transition, what you basically do is you support the environment to help them live outside of the pink or blue box that they want to live in. If it's a child who's gender exploring, who doesn't have a clear desire to socially transition yet, we do what we call watchful exploration. Family therapy, individual support, social support to see, can the child experience different kind of gender expressions, different kind of sense of self, and not rush to conclusions, and not rush to social transition, and not rush to a binary model. Some of the kids are just saying, I just need a little bit of space. And if it's a kid who is really highly gender dysphoric, who has distress about their body, distress about their sort of assigned gender, and has a cross-gender identification and wants to transition, then we'll look at possible social transition. Now, we don't jump into social transition lightly. It's a process of changing the child's name, pronoun, and identification in the world. And we do it if the family and the child meet certain criteria. First, is it a necessity? Is it crucial to the child because of their gender dysphoria and their clear, persistent, and consistent desire to transition? Is it safe? Is the family ready? Is the community ready? Do we need to do training with the school, with the family, with the extended community? We do trainings in churches, in people's homes. And is the family ready to be flexible? And to know that if you socially transition a young child, there's a chance that they would change their mind, and are you willing to invest all that energy and yet go back on that? At the beginning of puberty, which is Tanner stage 2, if the puberty increases that distress, that gender dysphoria, and the desire to transition, then we look at puberty suppression, because Tanner stage 2 can happen really young, depending on when puberty arises for each kid. And you want to give the child a few years to really be sure about their own identity. You can do social transition, but you don't do anything that has permanent consequences. So the medical protocol is puberty suppression, which is hormone blockers that basically pauses the puberty. If the puberty does not increase gender dysphoria, and that's sometimes the case, kids who are gender dysphoric and then puberty starts and they feel actually that their body is not betraying them and that they feel okay. They might feel like a very feminine boy or very masculine girl, but they're okay with their body. Then we continue to support that fluid gender expression and explore the new information that the puberty is bringing. It's only after 14, 16 that any usually cross hormones or more non-reversible interventions such as top surgeries are done, and genital surgery is usually not done before 18, even though it is changing in some places. The big question that parents have is, what is, will my child be transgender as an adolescent adult? And we don't have a way to predict. I'm doing a summary here of the studies. The studies have looked at which child persists in their identification as transgender. And studies have shown that about between 6 to 27%, the latest studies is around 27-30%, persist before puberty to after puberty as transgender. But in general, what's understood is that the psychosexual outcome is that about 75% will be, or 73% will be cisgender, so not transgender, of which 50% will be gay and lesbian and 25% will be heterosexual. However, I would just say that, if a child is clinically referred and has had for many years a high intensity of gender dysphoria, it is possible that if they show the criteria that you see here, that they are more likely to become and continue to persist as transgender identified than not. So the criteria, the characteristics of children who are most likely to persist in their identity as transgender adolescents and adult are insistent. They've been really insistent. This is not like a little bit of a wanting to be the other gender. It is clearly passion, a clear knowledge about themselves. They're persistent over time for more than 6 months, and I would say more than several years, and consistent in different contexts. And often also they meet diagnostic criteria according to the DSM. They have an earlier onset. It started earlier, younger. They're uncomfortable with their body. And then we'll see that in some certain standardized assessment questionnaire, they usually score higher. And they are also the kids who tend to be more socially transitioned. Now there's a question of what's the egg, what's the chicken. You know, does socially transitioning kid make them more likely to be transgender as adults or vice versa? We don't know that, but clearly there is a correlation there. Let's see if there are any questions here.
John, can you hear me?
Yeah.
The only question actually could have waited till the end, but I thought I'd let you know. There's one other question came in. Someone wants to know if the slides can be made available as a PDF. We have the mailing list, and I suppose we could ask people to let us know if they want it. But it is going to be up on the YouTube channel, so people can see it again.
Right.
What do you think?
I might have to take some of this stuff out as a PDF, and I'm happy to share some. Yeah.
Okay, so why don't we, Jason, why don't we ask people to email webinar@familyprocess.org and say if they want a PDF, and then we can send those emails to Jean. Sound good?
Good.
Okay.
Great.
All right.
On to the clinical framework. So
there is one other question. There is one other question. Just came in. The question is, I'm curious if there's any information about how many adults begin expressing the trans identity in adulthood that may have never had any inclination or desire as children.
I don't think that we have statistics on that, so I couldn't answer the sort of the how many. I think that what's important to understand is that there isn't one transgender narrative. There isn't one gender journey, and that some kids come out at the age of 2, some kids come out at the age of 18, and one is not more valid than the other. And some in general, the research shows that adults who come out later in life as transgender had a very clear, consistent history of gender dysphoria, of distress, but that had not been either really kind of clearly, that they didn't know what to do with, or didn't know how to express, or didn't get the support to express and work through. So people come in at all ages of life, and usually that sense of discomfort, that sense that something is different, has been there really early on. Okay, so
John, just a time comment. It's now 1:21, and we'd want some time for Q&A. So just so you can.
I'm aware of it. That's why I'm moving on.
That's why you're hurrying. Okay, I'm off.
All right. So the clinical framework. So here is, how we work the multidimensional family approach. The clinical sequence is that we start by seeing parents, and I'll show you why, and then we do an assessment with the child, and then we offer a number of modalities. So, and we don't think that every gender non-conforming or trans kid or family needs therapy, but we are happy to provide that individual therapy, that parental coaching, that family therapy, as well as the community. So it's really sort of an a la carte depending on the assessment of the family, the assessment of the clinician, and sometimes, as we saw with some of the gender nonconforming kids, it's not so much about making it a psychological process, it's about making it a social process, that they are fine, they're not in distress, but their environment, their school, their community, their medical environment might not be sort of attuned to their own sort of gender culture. And this is where we need to then intervene. So intervention is really sort of multi-modality and multi-level. Usually on the left of the screen you see a little movie, but that was a clinical, so I had to take it out. The tools that we use at Ackerman are multiple modalities. Again, we will go from individual, parents, family, and group. We use the decision dialogue developed by Marcia Scheinberg and Fiona True to transfer information between modalities. And I, being trained by Ken Hardy, often think about the multiple alliance. We think about how to create alliance and an engagement with the different parts of the system that often have very different feelings. Our goals are to both, sort of really join the different members of the system in different ways and in authentic ways. And the assessment with parents includes the following. We meet with them first to create the alliance, because we want to give them the privacy of naming their feelings about what's going on. Sometimes it's not something you want the child to hear or hear more of. We do a family genogram. We understand the structure of the family, the cultural context, the resilience, the conflict, who could be invited in the system, who might be a point of conflict, and also who is in crisis, who has an agenda. Sometimes the kid is not the one asking to be seen, doesn't have a problem with the gender, but the parents have. So are we going to do parental coaching? Are we going to do family therapy? Are we going to support the child? That's where we decide that. We do a detailed account of the gender development going from birth to now. We try to identify the intensity, consistency, and persistence of the gender dysphoria. We do an extensive evaluation of the emotional, social, and school functioning. And we really try to understand what's the level of social integration and safety of the child. Research shows that transgender youth tend to underreport by 90% their bullying or teasing or harassment in the social context, so it's very important. Zooming in on assessment with children, a tool that's helpful is the drawing of a person. Usually the first person that a child draws when we say draw a person is the person that has the gender of their own identity. So here Elsa is 8, socially transitioned at the age of 7, assigned male at birth but identifying as a girl, draws a first person as a girl, and then when I ask her to draw herself, she adds the color, but it's pretty much the same person but with the color. We use a number of other measures that I won't have the time to describe, but that are standardized, that really focus on gender identity development. We do a lot of observation of gender type behaviors, role plays, fantasy games, play with dolls, and then also we use the scale. This is one version, again, from Dr. Aaron Jensen. We ask kids to put themselves on the masculine and feminine spectrum, both in terms of gender identity, gender expression, and if they're older in terms of sexual attraction and sexual behavior, to really let them decide where they stand. And that scale can be done at any session all the time, can show how things move. Kids don't, it doesn't have to total 10. So kids could be a 9 on the male masculine spectrum and a 5 on the feminine spectrum. Again, breaking the binary. This is a number of scales and validated instruments that we use in the assessment of children and adolescents. And this is an important graph because even though it's a little reductive, which really try, there's not one size fits all. And we really try to look at each profile differently. And we, in a way, identify 3 subgroups of kids in our assessments and clinical work. You have, in a way, the trans kids who are really, really distressed about being seen in the gender that they've been assigned at birth, who are very, very consistent, persistent, and insistent, who want to socially transition as soon as they can, who want to medically transition as soon as they can if they know that's available. And the emphasis with them is often to support that, to support the family in that process, to support the social transition. Now you have kids who are on the other end of the spectrum, the gender non-conforming kids, who don't want to transition. They're comfortable in their assigned sex, but their gender expression needs more room. They don't want to be sort of squeezed in the pink or the blue box. And what we support is the family to be more okay with that, to look at the school, to look at whether, in a way, gender stereotypes are heavily preventing this kid from being who they are. And then you have the kids in between, gender exploring kids who have gender dysphoria, have some distress, and not very clear about whether or not they want to transition. They might be kids who are more sort of in the middle. On the spectrum, on the gender spectrum, and kids who don't know yet, and it's a developmental issue, with whom we then recommend sort of exploration. Can the parents do small social transitions, sort of on vacation, just for 1 week? Can the parents not jump to conclusions? Can the parents not go too fast? Because we encounter a lot of very supportive families who experience a real difficulty in staying in the in-between. It's very hard to raise a child who's exploring gender and not clearly on one side of the fence or the other. So I'm going to move to the clinical vignettes. I need to move to another. Here we are. So my first vignette is a child who is...
What jumped out at me is the slowing down. You know, it seems really important to slow down. I think I learned a very long time ago when I was studying at the Mental Research Institute in Palo Alto. The phrase is "go slow," and go slow works. It's really important. The other thing that I appreciated is helping parents stay in the in-between. It's so new for so many people to even think that way. I mean, it's not new for you, but I think it is new culturally to think other than binary. I'm thinking of, I'm remembering what happened at the Academy Awards. I can't remember his name, who we now have a trending hashtag. I think it's Stay Weird.
Yeah.
Yeah. So it's you know, it's becoming very, very visible, these ideas, and very, very visible.
Let me actually say a couple of things about what you said. The go slow seems sort of an obvious good clinical practice. And at the same time, what I think, you know, clinicians and a lot of my colleagues, myself, my team deal with is that we're dealing with families who are very anxious, often for very good reasons, and who are very anxious to figure things out, and who might be concerned about some real social stressors and real social threats, or a kid who has a real pressing gender dysphoria, and who might not be doing well in other ways. So it is a real tension to go slow, to really bring everybody in, to really create a container, to really create a sense that we are going to figure it out. We are going to create a process in which they can make, it's the both and, room for both the concerns and the love, the acceptance and the social reality. So to really think back to these functions, the parental functions, and to really name that with the parents. How do we help them transmit and socialize and at the same time nurture and accept? Can be really challenging.
Right. So I have some questions. They're not about the clinical vignettes, and so Jason is now recording again. And I'm not going to do them necessarily in order. I'm sort of going to try to group them.
Okay.
One question is, what medical non-binary transitions have you seen? I work with many GNC non-binary clients. I just lost the question. Who are seeking non-binary medical intervention. So I am wondering if you have seen that as well.
Yeah, so I would say that I've experienced that more in older teens and in adults, young adults and adults that I work with, where people are really sort of defining their own way of being comfortable with their own body, and who might not want to, in a way, sort of take on the entire protocol of hormones, top surgery, or a breast implant and genital surgery, but who are really sort of figuring out, again, the best, most comfortable, optimal way to live in their own body and embody their own gender. And so we have seen that, and it's something that is often, because when we're talking about children, we're talking about preteens, we're not doing anything really medical. There's nothing medical happening. The only thing medical that happens is around the very beginning of puberty, by the time they become adolescents, young adolescents, which is the blockers. And the blockers is the hormone blockers that stops puberty for a little while. So we're talking about here older adolescents, much older adolescents, and adults. And yes, I think that we are sort of, I would say, mandated to really think about the narratives that we have about the right and the wrong body, the right and the wrong embodiment of gender, and support, while doing a thorough assessment, obviously, support clients in their non-binary embodiments.
So, John, another question. Do you have any suggestions on how to incorporate your gender-sensitive approach in short-term therapy? For example, acute inpatient psychiatric care after a suicide attempt, where the family and the teen may be in multiple crises. That would be very hard. So.
Yeah. Well, yes, it would be hard. It would be hard, and at the same time, often, I don't want to say often, but sometimes it is the crux of the problem. So we're currently working with a family where the child has been hospitalized many times, and one of the triggers for the dysregulation is the gender expression and the way it lives in the family, or doesn't live well in the family. So I think that for the psychiatric team, for the assessment team, for the pediatric team to be aware of the questions that they ask, of the kind of whether they leave even the possibility for a child to identify in their own way, to ask them, how they identify in terms of gender. Do they identify as a boy or a girl? Do they identify as, what pronoun do they want to use? He, she, they, for the forms to reflect that as well at intake, at assessment. I think really can be so relieving for a child, and can also be tremendously relieving for a family. Sometimes the families struggle with this, but often the families that we see in our project are on board with the kid, but are really struggling to find psychiatric, mental health, and social services that will reflect the world they live in. So when they find a school or a therapist or a hospital that has the box for transgender or for please describe, it's amazing. It's amazing how they feel seen.
Yeah. That's changing too, I hope. So you know that.
It is changing, but I think that to really include these questions and to really unpack our conception of gender and sexual identity at assessment in a systematic way, in the way we ask any client, any family, the way we do any intake, the same way we do a genogram, the same way we ask the family's ethnicity, background, to ask them about how they see themselves in terms of gender, gender expression, gender identity. It could go very fast and be a no-brainer, and it could also bring a really important information for the family.
Right. So here's a short question, which might have a short answer. The question is, where might I access the various assessment tools referenced in the presentation?
That is a short question, but not a short answer.
I'm sorry. Okay.
So it really depends on each tool, and some of them have to be bought because they're protected, and so they need to be bought by whoever has published them or created them. Some of them are published in paper, so I will. What I can do is I can certainly put the list of tools in the. I mean, I presented it, so it's back on the tape, but it's also would be part of the PDF, and people can research them. There's also, I have a bibliography that includes the tools.
We have 10 minutes, but I only need like 3 at the end, so can we do a couple more questions?
Absolutely.
So this is, are assessments for disordered eating incorporated into the clinical assessment and treatment processes, especially among those with gender dysphoria?
Can you repeat the question? I didn't get it.
No, this person is asking about the relationship, I think, between gender dysphoria and disordered eating, because she's saying, are assessments for disordered eating incorporated into the clinical assessment and treatment processes?
For disordered eating, for eating disorder.
Right.
Not that I know in a systematic way. So I'm curious about where that question comes from, and whether that's been something very relevant for the person who's asking the question clinically in their work. But I think that in most extensive gender assessment, there's clearly, as I talked about, a thorough evaluation of the child or the young person's emotional, social, and interpersonal well-being and functioning. So I think that other symptoms, other areas of distress often come up and can be either just sort of comorbidity or can be secondary to the gender dysphoria or to the distress. We really don't work with a psychiatric or pathologizing approach, and yet we do screen for other forms of areas of distress. So eating disorders have come up. They're not the most common. I have to say that the autistic spectrum, attention and hyperactivity struggles are more common. Often the kids have regulation issues, and it's often secondary to the gender identity issues. If you don't feel seen, or if you struggle to see yourself, I think it can really impair your ability to learn, your ability to interact, to soothe yourself. So, but we do screen for all of them.
Yeah, I think the key is what you just said. If you don't feel seen, and I think disordered eating can come up around that very, very easily. So another short question. Any data about how many trans go through the surgery?
I am not aware of an overall number in terms of how many transgender individuals decide to go through genital surgery. I'm assuming that's what we're talking about here. Often when people ask about surgery, they mean genital surgery, not other forms of surgery. But I will show this one piece of research, two pieces actually. This is a study that's been done on 70 gender dysphoric adolescents in the Netherlands that were eligible for puberty suppression at the age of 12, so the blockers, and they were evaluated later on when they started cross-hormone at 16, and then after surgery at 18, and they also included children who got on puberty suppression earlier than 12. And they all met criteria for, at the time, gender identity disorder. And the results were very interesting. The results showed that first, that protocol of stopping puberty and then inducing puberty in the other gender had a clear positive effect on behavioral, emotional, and depressive symptoms. The general functioning improved, and no adolescent withdrew. They all pursued cross-hormones. So that's interesting, because that means that that kids who by the age of 12 here have been persistent, consistent, and insistent are very unlikely to change their mind. And that the post-op group, so the after surgery, are satisfied and no longer dysphoric, no longer in distress, and there was no long-term side effects proven, such as bone density and other form of medical issues. Now, another one, quickly if I can, Vicky, is a more recent study that's been done on the psychological outcome in young adults of about 55 trans women and trans men who have gone through that whole protocol as well, suppression, cross hormones, surgery, and they were assessed in terms of how they were doing in terms of their gender dysphoria, their sort of happiness in life, and how they were doing in a psychosocial way. Gender dysphoria was alleviated, psychological functioning was improved, their well-being was similar to or better than the general population at the same age. They were satisfied with their appearance and non-regretted treatment. 95% of mothers, 80% of fathers, 87% of siblings were supportive of the transition. And they actually a higher percentage of them accessed grad school than the general population. So this is in the Netherlands. This is a different cultural context. This is an N of 55. It's a very rigorous study. done over many years that shows that with the right support, with the right context, with a multi-systemic family support, medical support, these kids can do well, do not regret their decisions, and can live happily. So I think that's an important message we need to remember.
John, that's great. I'm going to thank you now because I'm going to move to show people how to access your articles. So I think I don't know how to thank you. This was wonderful. You're a great presenter. I think I've heard you present before, but I'd forgotten how good you were. And this information is really valuable. There are other questions that came in. There's just not time to ask them. And if you want them, I can make sure they get emailed to you, I think. I can make sure it gets emailed to you. So what I'm going to do is show people how to access your articles. We good for that?
I'm no longer on screen?
You're on screen, and I think you'll still be on screen while I show mine.
But
so
not my screen.
Not your screen. Your screen's no longer on, right?
Got it. Okay.
Okay. So what I want people to do is to begin to understand how they can access your articles. And what you need to do, I'm going to take you through the steps, is go to a browser that you might have, go to the search function, and type in family process. Once you do that, what will come up is what you want is family process all issues Wiley online library. So that's the site you want. When that comes up, you will see the family process library. I don't know why it's doing what it's doing right now, but I'm going to go to that and to the current issue. If you want to find Jean Malpas' articles, you go to the search function and you go to Jean Malpas. Now I don't want it in this issue, I want it in this journal. And what will come up are his articles, Between Pink and Blue and Breaking the Mold. There's also another article that will be free to download by Arlene Lev that speaks to some of the same things. So this is a way for you to get his articles. I certainly hope that you will do that. I think you'll be happy to do that. I hope you're happy to do that. And again, John, thank you so much for doing this. This is a real treat, real pleasure.
My pleasure. And thanks for everybody to join us.
Thanks for everybody to come to New York and be in your office for an hour and a half.
That's the most I've had in my office.
The most you've ever had in your office. Great. I love it. Okay. All right. I think I'm going to take my screen off.